Hi, good afternoon. I'm Keith Carollo. I'm a pediatrician. I have a kind of long history in medicine. I started in the 1970s. I worked as as kind of like an orderly in a locked psychiatric unit, which was pretty interesting and got me interested in medicine. I worked my way through my undergraduate as a nursing assistant. I went to nursing school, worked my way through medical school as a nurse. When I got out of medical school, I did my residency at Children's Hospital in Oakland and followed that up with a private practice for about 10 years. I always had a desire to work in hematology, particularly with people with sickle cell disease. And after I'd been in practice for a while, I decided to make that a reality. And I joined the hematology department at Children's Hospital. And initially, I was running both the sickle cell and thalassemia program. But when we started something called apheresis, I focused only on sickle cell for the next 15 years. Since then, since I left Children's, I've worked with a couple of community-based organizations and given some talks here and there. And in a week or so, I'm going to talk at Stanford. And so that's basically it. And maybe Pat can tell us something about herself.
So I am Pat Corley, and I'm actually a nurse by profession. I have been working with people with sickle cell disease since the early 80s. I actually also kind of followed Keith's path. I was in mental health nursing before, and then after learning about sickle cell disease, switched over into the sickle cell arena, where I thought I could better help people with sickle cell disease to live a more productive and meaningful life, and to ensure that they got the care that they needed as people living with sickle cell disease because of all the injustice that that they suffered at the hands of healthcare professionals. So I was recruited by a doctor, Dr. Cage Johnson, to help him to develop one of the first sickle cell programs that provided care to adults living with sickle cell disease in the state of California. And I am actually in Los Angeles in Southern California, where I practice at University of Southern California Medical Center.
Okay, so Pat, if you want to chime in anytime while I'm giving this talk, just go ahead. So what I'm going to do now is I'm going to be sharing my screen, and I'm going to give a talk about pediatric care and sickle cell disease. And basically, it's going to be the way I practiced. And I'll share my screen now, and then we can get started. Okay, so there's so what this is going to be, my part of this is going to be about pediatric care, and the end is going to be a little bit about transition, which segues into adult care. Let's see if I can change the slide here. I guess I have to use this. So I don't receive any compensation. This is my little disclaimer from any kind of medical or pharmaceutical industry of any type. This presentation, this is important. This presentation is my opinion of what constitutes good medical care and may not be shared by other physicians or other people, even patients. The recommendations in this presentation do not correspond to current practice, and they do not constitute recommendations for diagnosis, treatment, or care. The ASH clinical guidelines, that's the American Society of Hematology, with published guidelines for sickle cell disease, do not recommend screening. But as a pediatrician, I feel that screening is a very integral part of good pediatric care, and certainly for adults as well. So this is what we're going to be talking about, the incidence of sickle cell. I'm going to spend like one slide on adequate, what could be called adequate care, and then the rest of this presentation will be on what's optimal care. I'm going to talk about the way children undergo a lot of changes between 2 months and in 20 years, as you can imagine. So there's a first visit, we have infant visits, preschool visits, school age visits, early adolescent visits, and then adolescence, which goes into transition. And in reality, a pediatric hospital can really is authorized to take care of people until they're 25, but we like to transition people before that, usually by the time they're 21. Along with all this, we'll be talking about penicillin vaccinations. We'll spend a lot of time on transcranial Doppler and neurological problems, and then a little bit on disease modifying therapy. When I was practicing, there was nothing except for bone marrow transplant and hydroxyurea. And even now, the 3 new drugs that have come out are not approved for children. So this is what it looks like in the state of California. So this is from the CDC, and they work with California. And so you can see that most half of people who have sickle cell disease are living in Southern California, where Pat is. Most of the people in Northern California live sort of, I guess you could say, in the greater Bay Area, in the between San Francisco and Sacramento. There are a lot of patients in the valley around Fresno as well, but easily over 50% of the patients or people with sickle cell disease live in Southern California. And this is the ages of people who have sickle cell disease in California. So you can see that where the box is there, this is how many people, these are the number of patients. So this is how many people live in this age group as pediatrics. You can see the numbers of people who are adults are way more than children. And these are the ages that they occur. And this is the dark is the males and the lighter is the females. And so what's adequate care? Somebody actually asked me this question.
Females have it more than males.
Oh, yeah?
On that chart.
Somebody actually asked me what adequate care was with sickle cell disease as opposed to what I thought optimal care was. And so I think adequate care, if you had a clinic for sickle cell disease, you'd have to have an MD provider. It could be an adult doctor, hematologist, or a pediatrician if you had kids, and then a nurse practitioner or some other advanced practitioner, probably a nurse, and then for sure a social worker. The clinics would have to be open 3 to 5 days a week, maybe not all day, but at least 3 to 5 days a week. They should have emergency room and hospital access. They should probably be near an emergency room. They should have access to red blood cell transfusion, which is complicated for people with sickle cell disease, and access to subspecialists. They should be able to do transcranial Dopplers if they take care of children, cardiology, pulmonary, neurology, and nephrology or kidney care if they take care of adults and children. And then access to new therapies. So the physician who was the provider would have to be familiar with hydroxyurea, Oxbryta, and the other Indari, the other new therapies that have come out. And they should also have the ability to refer people for a bone marrow transplant. And this would be beyond what's adequate, but they should also have some connection with research as well. So this is what I personally consider optimal care. And I'm biased because this is the way I take care of people. So maybe it's not optimal, but it's what I did when I was doing this. So
So,
this
so
is
Keith, I think there are a couple of other things that
sure.
I know you're talking about hands-on medical care, but I
Yeah,
think
yeah.
I think it would be optimal for me would be if they also have rehabilitation counselors
Yes.
who helped individuals to navigate, possibilities of workforce and all of that kind of stuff that we don't often focus on.
Right. That's particularly with adults, because adults need that extra help to most people are just not familiar with the way the systems work. So for optimal care, and this is the way I practiced at Children's Hospital in Oakland when there were national sickle cell centers, which was 1995 when I started through 2005, and I went on beyond that. But in 2005, the centers were all defunded, and there were no more sickle cell centers. Although they continued to exist, they just didn't have the kind of funding that they had when I started taking care of people with sickle cell. So there was a pediatrician, a hematologist, nurse practitioner, social worker. We had a psychologist who came to all the clinics. We had a genetic counselor who came to all the clinics, as well as a social worker. And we had a day hospital nurse coordinator, because we needed somebody who was familiar with sickle cell disease and would help us get people in for care for pain episodes, transfusions, that kind of thing. So the optimal specialty care would be radiology imaging, particularly for MRIs, MRAs to rule out stroke, cerebral vascular disease, transcranial Doppler. At Children's, when I was there, we had our own transcranial Doppler operator who had been in the studies, and she was very good. She could do studies on 2-year-old children. Neurology, neuropsychiatry, which these are really important. Neuropsychiatry, which does neurological testing for people. That's really important for adults. Cardiology, pulmonary, orthopedics. Physiatry is a doctor who's like a physical therapist, but they are an MD, and they are very good at diagnosing problems and making suggestions. And then transfusion medicine. All of these things would be what you would consider optimal for adults as well. So these kinds of specialty care should be available for everybody who has sickle cell disease, regardless of how old they are. So the clinic should be open 3 to 5 days a week with time allotted for illness visits. One of the big problems with sickle cell disease is if you get sick, you have to go to the ED. And it would be much better if you could go to an office or a day hospital and be evaluated and never have to be seen in an emergency room and be seen by people who knew you and knew about sickle cell. We had specialty clinics for stroke, orthopedics, and cardiology and pulmonary. So children and young adults who had had a stroke or had other neurological problems, we had a special clinic once a month for them. If they had AVN, we had, or avascular necrosis, usually the hips, but other areas. We had specialty clinics for them, and then for cardiology, for pulmonary hypertension, and for pulmonary, for asthma. Kids with sickle cell have a lot of, they have more asthma than average, and Blacks have more asthma than the general population. Part of that could be because of where you live. If you're urban and you live out, well, where I live, there's a big oil refinery out there in Richmond, and people who live near that, they have pulmonary disease. You need a day hospital for chronic and acute transfusion and pain management, and an emergency room. And because I was across the street from the hospital, I would go to see the patients in the emergency room if I had the time. And I would also be available 24/7 for consultations. Inpatient care with social services and psychology. When you're in the hospital, you really need to be supported by the social worker and a psychologist who knows you. You should have exchange transfusion for chronic transfusion, and exchange transfusion should be available the way it was when I was doing this, 24 hours a day, 7 days a week. I would come in to the ICU at any time to, and so would my team. We would come in and they rotated, but I was the only doctor. So to give an emergency exchange transfusions to somebody who was in the ICU, really sick with sickle cell disease. And then a surgical team that knew about sickle cell disease, especially orthopedics. So where did all these sickle cell centers come from? When I started taking care of people with sickle cell disease, I thought, wow, it's really weird. Richard Nixon started the sickle cell programs. He funded 10 sickle cell centers in the country. Why would he do that?
Yeah.
I mean, he was not exactly a friend of Black people, that's for sure. Well, the fact of the matter is, the sickle cell centers would not exist today if it was not for the Black Panthers. Absolutely. So Black Panthers started in the 60s and the kind of late-ish 60s, and in the news, and you know, they didn't have social media then or anything. But what you read about the Black Panthers was, especially if you were white, they tried to used the Black Panthers to create panic about Black people. And so what they did was they characterized the Black Panthers as young people armed with guns who were going to be not in their community, but in your community. And so it was a mass. It was the white majority in this country in the 60s and in the 70s. They had a focus of how, you know, it's a suppressive white supreme country. So now they had a target, and that was the Black Panthers. And this went on for years until 1982 when they disbanded because the FBI had killed so many people and so many people were incarcerated. So, but in 1972, the Black Panther Party started health clinics because they realized they made a big shift in their focus. At the beginning in the 60s, the Black Panthers protected their community with armed people from the police, which they, you know, what's going on today was going on then. You just never heard about it. And then they had social programs, they had food programs, they had schools, they had helped people with rent. They would go shopping for older people. They got people to vote. And this was all over the country, and it became international. There were Black Panthers in Europe and in North Africa. Anyway, so it was huge. But in 1972, they realized that, you know, you can't fight the government because they have the army, and you've got to go back to where you started, which was the community. So they revitalized all their community services, but they started health clinics. And the reason why they started health clinics was because they made the connection that most Black people lived in urban areas. There were big hospitals in urban areas. Sickle cell disease was really common among people among Black people, but nobody knew how common because nobody tested. Nobody. You had no idea that you had sickle cell disease or sickle cell trait until you got sick or you had a kid with sickle cell disease. So they started testing, and they made the focus of their party or the health clinics to test every patient for sickle cell disease. They used something called a solubility test, which wasn't very accurate, but if it was positive, it meant you either had sickle cell disease or you had sickle cell trait. So they would send those people to a hospital for diagnosis. In Berkeley, they had a lab tech who would do the hemoglobin electrophoresis right there on the spot, and they would be able to diagnose you. The other thing about these health clinics, they were not staffed by random people. These were licensed physicians who volunteered. So these were real health clinics in the Bay Area. The Public Health Service actually supported the clinics for the Black Panthers and helped them create the clinics. And the emphasis again was on sickle cell. But in 1972, a Black Panther and Yoko Ono and John Lennon were on a national TV show talking about sickle cell disease and the lack of care generally for Black people, but they were focusing on sickle cell disease. There were millions of people who saw that, and it made a really big impression on white people. They realized, wait, what is going on here? And so in order to, and the Black Panthers, they had a sickle cell program. They created a foundation for research in sickle cell disease, and they had community involvement, as you can see in that picture. And so the government, in order to undermine the Black Panthers, because they had way more money than the Black Panthers, they created the National Sickle Cell Disease Control Act. Through that act, they gave millions of dollars to create 10 sickle cell centers throughout the country, and it was competitive. So Cage Johnson down in LA got money to start a center. Elliot Fachinsky got money up in the Bay Area to start a center. And then there were centers in Chicago, Boston, Florida, Texas, and Alabama. There were 10 altogether in the country. And so what was this National Sickle Cell Act? It was exactly the same thing as the Black Panther Party. They had clinics funded by the government, they had testing funded by the government, and they started research. So all 10 of these centers around the country would combine their resources and did a lot of really huge studies on sickle cell disease funded by the government to define how many people had sickle cell disease. How do you take care of acute chest syndrome? What about strokes? What about the other problem with sickle cell disease? Anyway, there would be no centers. I wouldn't be on this talk right now if it hadn't been for the Black Panthers. So the first visit to a clinic.
Dr. Keith, real quick question.
Sure.
So Julie asked, what qualifies an SCD patient to get exchange transfusions? Since
What qualifies somebody to get an exchange? Is that the question?
SDC patient.
Oh, sure, SC, sure. Okay, so people with SC disease have very high hemoglobin. So their hemoglobin, like probably people with sickle cell disease, their hemoglobin, or SS, their hemoglobin runs somewhere, they can be really low, but it runs somewhere between 7, 8, 9, maybe at the very, very most. Whereas people with SC, their hemoglobin runs from about 9 or more, all the way up to 12. So if they get sick, if they have acute chest syndrome, if they have multi-organ failure, which is actually more common in SC than it is in SS, that you can't do a transfusion, because if you over-transfuse people with sickle cell disease, it fluid overloads them, the blood becomes more viscous or sticky, and it can cause strokes. So you can't, when you transfuse somebody with sickle cell disease, SS, you can't, well, you don't want to go over a hemoglobin of 10 or 11, because then the blood becomes more viscous, and the people have died from being over transfused. An exchange transfusion, though, it removes blood from the patient. Simultaneously, you're getting blood. So your hemoglobin, well, it changes a little bit, but it never really changes throughout the entire procedure. So you're never anemic. You don't have hypoxia or anything like that. And that's really important with SC, because they start off with such a high hemoglobin, you couldn't give them a transfusion. So if they had multi-organ failure, you couldn't do anything. You could do a manual exchange maybe, but an automated exchange, you can exchange 60, 70% of their blood and give them normal blood in a matter of hours. So gotcha. That would be the indication with acute chest syndrome, multi-organ failure, or some other really serious problem with SC would qualify for an acute exchange transfusion. With SS, what you actually have to do is you have to give simple transfusion. So usually when people with SS get sick, their hemoglobin goes way down, like to 5 or 6, even lower. So you can't do an exchange transfusion if you don't have any blood to exchange. So usually with SS, you top them off with a regular transfusion to make their hemoglobin 9, and then you start the exchange transfusion so that you want their hemoglobin S to be below 30%. You want their S to be below about 60%. So they have 30, kind of like trait, 30 to 40% A, the rest is S. So that's
Gotcha.
the long story. So anyway, the first visit to the clinic is mandated by the state of California. All children in California are in the country now. All infants are tested at birth, and if you have a positive test in California, you're mandated to, your pediatrician is notified, and you have to go see a sickle cell center. And at the center, you are your baby is retested, because I've never seen it happen, but of course, you know, things happen in medicine. They could mix up samples or something like that, and your baby might not have sickle cell disease, and they got mixed up. That I've never seen that happen, but that was the reason behind this. So we made a diagnosis. Sometimes it would take DNA. If you had a really unusual type of sickle cell disease, it would be more difficult to make the diagnosis. But if you had SS, SC, beta thal, it was done in a day or so. And then if there was enough blood, we could talk about it later, but a red cell phenotype or genotype before people would get a transfusion. So we took the opportunity that the people were coming in with their child anyway. So we did, I'd spent over an hour. I talked about penicillin prophylaxis, fever and infection, and review some of the common complications in children. One of the things that I tried not to do is overwhelm people with too much information. I just told them, as the babies and the children grew up, I would start introducing new things. But for babies, the big thing is penicillin, fever, and infection. Back in the day, before there was sickle cell centers, most children, and in Africa for sure, now, today, most children do not grow up to be 5 years old. They die of an infection before they're 5, usually around the age of 3. And this is what was happening in this country before the penicillin study in 1988 or something like that. And so this was a visit so they would be able to be introduced to sickle cell disease and reassured, we're here to help you. They had a first visit within the next month or less, and we did a family history. It's really important to know about their family history, because hypertension, pulmonary disease, and kidney disease for sickle cell trait and sickle cell disease are important to know about, because those are things that are very serious in sickle cell disease. You need to know the family history of sickle cell disease, because that's going to really sort of determine the interaction you're going to have and how people feel about sickle cell disease. So when I started in 1995, the care for adults prior to that, and even now, but prior to that, was like non-existent. So a lot of people had an uncle, an auntie, or somebody who got really sick with sickle cell disease, and they died very young. And they thought that was going to happen to their kid, their baby. And so that was part of us to reassure them that things were going to be okay. They got to meet the team members. They learned about disease modifying therapy and research. We did a lot of research at Children's, especially in the 90s. And we reminded people that their participation in research was important, but voluntary. And whether they were in a study wasn't going to affect their care. Seriously, I guess I really didn't care if they were in a study or not. I thought that they should be, but it didn't, you know, it's a personal decision. Anyway, and we tried to tell people sickle cell disease is manageable, and your team, our team, will help you with your child's care in every way we possibly can. And we're here every day for you. So we would see the babies every 9 to 12 months. We review the complications, fever and infection, splenic sequestration, showed moms and dads how to feel for the spleen, talked about acute chest syndrome if respiratory infections were serious. And we did some blood work twice a year, usually. Sometimes if kids were very anemic, we'd do it more often to kind of get a baseline of where their hemoglobin was and stuff like that. And we'd start immunizations. Basically, children with sickle cell disease get the same immunization as every other child, except they do get the pneumococcal 23-valent or 13-valent pneumococcal disease, pneumococcal vaccine. There's other things we could do. If the baby seemed to have a low, small red blood cells, you can test for alpha globin gene, which affects SS. We could diagnose S beta plus thalassemia because there's 250 different types of beta thalassemia, and they had variable levels of hemoglobin A. So we had one patient, people thought she had S beta 0 thalassemia, which is the same as SS, but she really had S beta plus. We do chemistry, we did breastfed babies, we supplemented them and gave them iron and vitamin D. Penicillin prophylaxis starts at 2 months, 125 milligrams twice a day. But we had to remind patients the risk of infection exists with penicillin. There's 90 different strains of pneumococcus. Most of them are not pathogens, but a lot are. So even though you were on penicillin and you had been immunized against pneumococcus, there were types of pneumococcus that could cause problems. And antibiotic resistance in pneumococcus is pretty common. So this penicillin affects the membrane of the bacteria and stops all bacteria that are susceptible from making red cell their membranes. And so it gave you enough time to get to the hospital. It wasn't curative. It didn't stop the infection. It just gave you a few hours extra to get to the hospital. And then we gave him the Prevnar vaccine. Disease modifying for modification for children is still the same. We HLA typed all siblings for bone marrow transplant. When I was started, hydroxyurea was not was in sort of the infancy. It started about 10 years before I started taking care of people with sickle cell disease, and we gave a few people hydroxyurea, but it really didn't take off until I'd been practicing for about 5 years or so. It's been shown now to decrease the incidence of conditional TCDs and pain and acute chest, which we'll see about TCDs as a risk factor for stroke. And it's been given successfully to children as young as 2 to 6 months of age. I never did that. I would usually start by a year or so, but we didn't know as much about hydroxyurea when I was taking care of kids as they do now. The new therapies haven't been shown to be effective in infants or children, and they're not approved. But I would discuss, bone marrow transplant and other kinds of things as they came up with my patients. Transcranial Doppler is a big deal for me personally because I was around before there was before you could screen for strokes, and I saw kids die from strokes. I saw kids have severe neurological problems and paralysis from strokes. And when you have a stroke as a child, it's forever. You grow up with severe cognitive disabilities and mobility. And it's just a huge thing on top of your sickle cell disease to have had a stroke. So transcranial Doppler was developed and in the 90s. It was approved in the 90s, and it predicts stroke. So you could use an ultrasound. We'll talk about this in the next slide. But we would try to do one at 2 years of age, and then by 3 years of age. And then there was something called a conditional study that's not normal, but it's not abnormal. And we'd follow those up more frequently. And if you have a stroke risk, you got started on transfusion therapy for abnormal studies. Initially, We thought children would be on transfusions for life because it was shown that if you stop the transfusion, the children would have a stroke. So that was a huge burden for people. So this is what a TCD is. And it's, this little girl is now an adult, and this is not her. This has nothing to do with her. It just was in a journal. So there's an ultrasound. So it's completely safe. There's no radiation, nothing. It's just sound waves that look at the vessels. This is the biggest vessel in your brain. It's called the middle cerebral. And then if there's a posterior, anterior, this is actually part of the carotid artery. You can feel it in your neck. It goes up this way, but you could take this probe and look down here and you can see what the velocity was in that artery. So the way it works is, if you can think about it, blood is like water flowing through a hose. And if you kink a hose or you step on a hose, all of a sudden you can start hearing the water go through where you narrowed the hose. And that's because the velocity or the speed of that fluid gets faster when the narrowing of the hose. Same thing with the blood vessels in your brain. If you have narrowing of these vessels, no stroke, you just have narrowing of these vessels, that is a sign that you're going to have a stroke. And these were the velocities that we used in order to screen people for strokes.
Keith, I think it's also important to mention that adults have strokes as well, and that oftentimes they're not screened because people don't understand that stroke phenomena does not just exist in the pediatric population. And our patients actually progress to having bleeds into their head and losing their lives as a result of that. And so I think we really need to make people aware that this is not just a pediatric phenomenon.
Right. And we'll get into that in a couple slides here. So
also, Dr. Keith, real quick, Dr. Keith, could you explain Infarcts quickly?
Explain what?
Infarcts, you mentioned
infarcts. So
Infarcts
are basically the blood flow to a part of your brain is interrupted, or it's so, the flow is so low that oxygen can't get to your brain, and whatever area of the brain that that vessel was supplying with blood and oxygen, it dies, and it never regenerates. Once your brain dies and gets damaged, other parts of your brain might be able to take over for that part of your brain, but that particular area is gone. So that's why, as children and adults, if you have a stroke, you can lose your arm, you can lose your leg, but sometimes you can get some of that back because areas that haven't been damaged can actually take over. But the area that was damaged it's done. It's forever. So children with stroke risk with the TCD, where transfusion was recommended indefinitely. And when you get blood transfusion, there's a lot of risk to it, and you get iron overloaded. There's a lot of iron in blood. Your body can't get rid of iron, so you have to take medicine every day to get rid of that. And this was prior to something called the Twitch study, which we'll get into. The transfusion could be any type of either exchange or simple, but you wanted to get the hemoglobin S as low as possible. You wanted the S to be like 30%. So 60% of your blood would be transfused blood. That's really hard to do in reality, but that was the goal. And it did prevent strokes. Children on transfusion didn't have strokes. And during the study, some people who didn't want to be transfused, even after the study showed that it was protective, those kids eventually ended up having strokes, unfortunately.
Keith, Dr. Keith, I just want to, Nancy Renee has a question. Once someone has a stroke, is he more likely to have another?
What is a stroke?
No. Once someone has had a stroke, is he more likely to have another one?
Absolutely. In fact, yes, because it means that for some reason, you're predisposed to having stroke. So I've talked to adults who have had 3 strokes in their life. They had a stroke when they were 18, when they're 25, and when they're 30, just like what Pat was saying there. So we'll talk about that. But once you've had a stroke, you're at risk for more strokes. Even back in the day, when we would transfuse people for strokes, even though your percent hemoglobin S was like 30%, 25%, you were still had more strokes. So there was a possibility that even on transfusion, people could still have strokes with sickle cell disease. So yeah, so this trial for hydroxyurea had these, 26 centers. They had to be on transfusion for a year. If they'd had a stroke or if they had narrowing, that's vasculopathy. TIA means a transient ischemic attack. That means you look like you had a stroke, but within 24 hours it went away. And when you did imaging, you couldn't see any damage. And so they had 60 patients on transfusion, 60 getting hydroxyurea. Interestingly, decided that they were going to do phlebotomy on the kids who were getting hydroxyurea. They would take blood off to get rid of the iron overload, and the hydroxyurea would bring their hemoglobin back up to a higher level in the month between each one of these. So hydroxyurea does a lot of good things, actually.
So Dr. Keith, on those patients that were predisposed to stroke, when they made the decision of transfusing them, did they differentiate between doing an exchange transfusion or a simple transfusion? And what was the incidence of repeated strokes in those patients with exchange as compared to those with simple transfusion, which means keeping blood on top of other blood?
So in the study, this was in the mid-90s. It's the reason why I started the program for apheresis and exchange transfusion in Oakland. But basically, it depended on the hospital. Most hospitals couldn't do exchange transfusion. You could always do it with a nurse or 2 nurses, where one's taking blood out and one's putting blood in. But that most places didn't do that. And the study itself didn't really differentiate between the two. However, historically, after this study was over, there was an advantage to getting an exchange transfusion. So because the exchange transfusion could really get your hemoglobin S way down, way better than it. Because when you do a simple transfusion, basically you're hoping that the person who has sickle cell disease comes in and they're really anemic, because then you can give them more blood and you can reduce their sickle cell percent. But if they don't, like with SC, which they don't have strokes very much, but you couldn't transfuse them, so you could never get their S down. So the nice thing about exchange was no matter what your S was or hemoglobin, we could always do a transfusion. We could always get your S lower and lower. In the ICU, when kids were really sick, I had a kid who was really sick, and her life was saved by exchange. And we got her S down to 10% because she was just not getting better, but she did okay. So anyway, what this showed was in the hydroxyurea group or the transfusion group, there was no difference between the 2 groups. So it meant that you could, after a year, if you met criteria, you could go onto hydroxyurea. You didn't have to get transfusions anymore. You didn't have to worry about iron overload. And since you were on hydroxyurea, you were protected against other things as well, besides stroke. People with sickle cell disease on hydroxyurea do much better. Even when you're an adult, if you start late, it doesn't matter, it helps. I have a friend who has sickle cell. She's 72. She started maybe 13 years ago. She used to be on transfusions intermittently for the past. Once she started hydroxyurea, that was the end of transfusions, and she's done very well, and she's very healthy.
Dr. Keith, I need to stop you because there was a question earlier from Shirley Powell.
Yeah.
How do you get neuropsychic care
Oh, neuropsychiatric.
Yeah, this
care?
was probably further back.
Oh,
And then
yeah,
she said,
that's-
how do you get social worker care and all of that
Okay.
sort of thing? If you come in through the emergency department,
Oh, well, if you come into the emergency department, you don't get anything, basically. I mean, really, I'm laughing, but it's not funny. I just had someone call me
people
about
need
the
to
emergency room, and the emergency room is for emergencies. And a lot of people don't know anything about sickle cell disease in the emergency room, and they just don't know what to do. Were you going to say something, Pat?
It's not just that they don't know what to do. Those services are not available to them in the emergency room. They have a certain job that they are supposed to do, and that is to save lives and get you out of that facility as quickly as possible. So for neuropsychiatric problems, if you come in and you're a danger to yourself, a danger to others, or gravely disabled, they will send you to a psychiatric hospital or facility. But otherwise, they are just there to stop the bleeding, to keep you from having a stroke, to keep you from dying, all of those types of things. And so the emergency room really should not be used for mental health issues. We need to have a separate mental health area in an emergency setting for people who are having issues with mental health things.
Right. Yeah, and for neuropsych testing, that is something. A lot of these things, not social worker, but you have to be referred by a doctor. So a doctor has to refer you. Like Pat's saying, mental health issues. The emergency room is just not. I guess if there's an acute problem with someone's going to hurt themselves or other people or whatever, that might be appropriate. But otherwise, they don't know what to do with someone who's having a mental health issue in the emergency room. They will refer you for like they can do a 24-hour, 72-hour hold, but even that is not always available. Anyways,
So just to clarify, Shirley asked, once you're admitted at that point, unless you're having an episode, what they would do is just refer you to go see someone with mental care capacities at that point.
So once you're admitted, a consult would go into whatever services necessary for you to have. So if you're having a mental health issue, you're admitted to the hospital for pain. Your doctor, whoever that doctor happens to be that sees you, once they do their physical workup, and the physical workup is not just physical, it's a mental workup as well. And once they establish that you're having some mental health issues, they would call in a psych consult. And that person would come and see you, and then they would determine what needs to happen from there. Because you don't want to be just started on a mental health medicine without really having an evaluation to find out, is this really a mental health issue related to mental health, or is this a mental health issue related to damage from sickle cell disease that's causing me to do and see things differently?
Gotcha.
I mean, one of the things you'd want to rule out is this a stroke? Did this person have a stroke? And because a lot of strokes don't involve your motor system. So, the neurologist, if you were having a mental health issue, of course, you're going to see a psychologist or a psychiatrist, but also a neurologist because you have sickle cell to make sure that this is really a mental health issue, like Pat was saying. And the issue there, though, is the mental health in this country is really not good. So they would, and if you're having a mental health crisis and you have sickle cell, they would keep you in the hospital until that sickle cell event was over, because if you go to a mental facility, there's nobody there to take care of you medically. It's all about, psychological stuff. So if you were having pain or you're having some other episode with sickle cell, you wouldn't be able to be admitted to a facility. They would keep you in that hospital, send a psychiatrist to see you. evaluate
Right.
you, and then
Right.
once you were all better, then you could go somewhere. So that's kind of the way that would work.
And even when that psychiatrist comes to evaluate you, because they don't know who you really are or how you normally function, there needs to be a sharing of information that says that I'm not thinking the way I normally think. I'm not able to process things in the way I'm usually able to process them, or for your family member to say, he's different than what he normally is, or she's different than what she normally is. And we really think you need to check them more closely, because this does not seem like it's related to their typical expression of sickle cell disease. There's something else going on with them. And so I tell patients all the time and encourage them, you have to push hard, and you have to push from the very beginning, helping them to understand there's a differentness in this admission than there has been in previous admissions. And there is a differentness in the way we're communicating with each other, which says to me something else is going on with them. And with sickle cell disease, there's always a possibility of stroke. It does not matter how old you are. And there also is a possibility of bleeds into your head as a result of sickle cell disease and weakened vessels. So that we do have to be purposeful as we interact with healthcare providers to help them to understand the difference of each expression in at a time when they're receiving emergency care.
And that's one reason why you need an advocate. If you go to the emergency room, you may be if you're having pain or you're sick, you may not be able to communicate those things with somebody in the emergency room, but an advocate can do it. Just what Pat said. This is really different from the way this person usually operates. Right. So anyway, so this is just
and then sorry, she asked one more follow-up question. She said, what's neuropsychiatric care?
So neuropsychology is a way, it's testing. So the neuropsychologist performs tests. They're very, very lengthy and they're very involved. So somebody who has had really mental health issues where they were really depressed or something like that, that could be picked up on a neuropsychological exam, but what they're really for is cognitive ability. So a neuropsychologist tries to figure out, are you having problems with reading? For me, as the pediatrician, is a kid having problems with reading, with math, making decisions? Are they able to function in a classroom, that kind of thing? And it's usually about 3 to 4 hours of testing. So with kids, they break that up into hour intervals. So it'd take a week to do a complete neurological or neuropsych testing. And then, of course, you have to have a neurologist as well to make sure that this isn't, this is psychological, not neurological, like a stroke.
Yeah, and I would venture to guess that 90% of adults living with sickle cell disease never have that testing done after they leave pediatrics.
No.
And so things happen to adults with sickle cell disease where they come in contact with healthcare providers and they're not acting, quote unquote, the way they should be acting. And there's a lot of judgment and a lot of abuse that occurs within the sickle cell population as a result of that. And I think it's imperative that we start helping healthcare providers understand that not only do people have painful episodes, but they have episodes that damage their ability to think in certain ways or perform activities in certain ways. And I think we are very, we're poor communicators of that. And I think we really do need to help them to understand that people with sickle cell disease, though you may not see that they're different from the general population, there are things that happen within the pathophysiology of their disease process that does manifest in a way that changes the way they respond to the things that you say and do to them.
Right. So here is the cerebral vascular risk in sickle cell disease. So this is the risk over here, and this is age. It goes from 0 to 14. And this was a study done in pediatrics in conjunction with the STOP study and using TCDs and MRIs. And it showed that abnormal TCDs occurred in 30% of people by the time they were age 14. Stenosis, or narrowing of the vessels, which was diagnosed with the TCD, 22% of people with sickle cell disease had narrowing of some artery in their brain. Silent infarcts, which are teeny tiny little microscopic, well, not microscopic, but they're like they're 1/8 of an inch in diameter, very small. But those occur in 28%, and they don't have any, they're called silent because there's no way to diagnose them except with an MRI or maybe a neuropsych test, which would lead to an MRI. Anyway, 28% of children and young adults up to the age 14 had silent infarcts, and which means overall, by the time people with sickle cell disease are 14, they have a 50% chance of having some neurological problem. So that's huge. That's half of everybody with sickle cell disease. A lot of these, like silent infarcts, they are silent. You can have them and nobody, unless someone does an MRI, then you would not know that somebody had one of these silent infarcts. And there was a SIT study that looked at silent infarcts and whether or not blood transfusion could reduce the risk of more silent infarcts. What it showed was if you have silent infarct, you're at risk for stroke. So if you transfuse people with silent infarcts, the risk of stroke goes down. So this is kind of a weird graph here, but this is 14, about 14 right here, and this, or 16. And so 16 is when we stopped doing transcranial Dopplers. But you can see that this is 0. So at age 0, goes up to 70. So at age 0, nobody's had a stroke. If you go down here by age 16, about 10% of people have had a stroke. And as you go along this graph right here, more and more and more people have strokes until 70. But like what Pat was saying, here's 16 where we stopped doing TCDs. But you can see the risk of stroke has already really decreased in people with sickle cell disease. And when you're in your middle 20s, it's at its lowest. And then it goes up again. And when you get into your 30s to your 40s, it's again your risk of stroke goes back up. But look at this. This is what Pat was talking about, intracranial hemorrhage, very uncommon in children. But between the ages of 20 and 30, the risk of having an intracranial hemorrhage is the same as having a risk of a stroke when you're a child. And unfortunately, right now, you cannot predict who's going to have an intracranial hemorrhage. There's no test or study. But like Pat's saying, this is huge. These things happen to people with sickle cell disease, and the general physicians, people that don't know about sickle cell disease, don't really even know about this at all, actually. So now we're down to preschool. So now the kid is not in school yet, but he's in preschool. So we changed the visits. We have nutrition recommendations for children. Like some of these, we considered zinc. If we talked about zinc, it helps your immune system, etc. It's very important in your metabolically, and we talked to patients about that. About if kids were really small, if they were below 50% for height and weight, we did a diet history, sent them to a dietitian. Pica means eating things that aren't food. So when you're really anemic, like women during pregnancy, if they would get really anemic, they like to eat ice for some reason. Nobody knows why, but they like to chew on ice. And for children who are very anemic, because they have sickle cell disease, they would eat dirt, they would eat things that wasn't food. And so the trouble with that is that lead intoxication was relatively common, more common in people in children with sickle cell disease than in the population at large. So we really tried to get a history of pica, because then you had to worry about lead. We did lead testing if we thought we needed it. So at school, kids
Dr.
need a
Keith, if I could
plan.
interrupt you right there at that point. So just to go back to the hemorrhage, the intracranial hemorrhage, you mentioned that there is no testing available for it or a way to predict it, correct?
Right.
Okay.
Yeah, there's no test, there's no way to predict it. Usually, so what the few people that I saw with intracranial hemorrhage, they'd have a very severe headache, the worst headache they ever had in their life. They would just be in bed with the headache. And if they went to an emergency room with a headache like that, and it was really severe, and someone did a CT scan, you could actually see the hemorrhage. At that point, you need neurosurgery involved, and they can they can actually embolize or stop the bleeding and evacuate the blood from your brain. And they could, and you could come out of that with absolutely no problem. You know, you would have no neurological problems at all. But because you had sickle cell disease from that point on, at least from my point of view, you would be on chronic transfusions in order to prevent any more cerebral vascular disease. And we had a couple of kids who were on chronic, they were not kids, they were like in their 20s, who were on transfusions for intracranial hemorrhage. But you can intervene if you realize, oh, this person having a severe headache, this isn't sickle cell, this could be a hemorrhage, and you do a really simple test that takes 5 minutes, a CT scan. So kids in preschool, we wanted to make sure they had a school plan for illness and pain, a letter, a 504 plan, and we'll talk about that. We'd like to have the caregivers come so they could meet us and we could inform them, nutrition counseling, and even in preschool, kids who are like under 5, they could start having pain, but usually kids don't have that much pain before 5. And so we would talk to the parents about what to do when there was pain. They would get their routine immunizations, and at 5 years old, we increased the penicillin. And then we would teach, really important, the onus is, in pediatrics, the onus is on the parents. The kid's not going to come to see me in the clinic unless the parent realizes there's a problem. So the parent really needs to know more than most doctors about sickle cell disease. So the teaching was huge. So we would talk about infections, whether they were compliant or adhering to their penicillin, splenic sequestration, acute chest pain management. Do you know, we'd ask parents, do you understand all this and how to know whether this is happening to your child? And parvovirus is a virus that causes anemia. It's common in kids. People without sickle cell get it, and there's nothing. But what happens, the parvovirus infects the red blood cells when they're in the bone marrow, and you become really severely anemic and need a blood transfusion as a child. Priapism is really common in males, and we would start talking to the parents about priapism so they would know that this was an issue for their children, and they would be able to make a referral. And before the kids ever got a transfusion, we talked about transfusion, why they would get one, the possible complications, that kind of thing. And, you know, in adults, education is not a big deal in adults. I've talked, I know a lot, not a lot, I know a few adults with sickle cell disease, and they're on hydroxyurea. They don't know what the doctors never told them what their fetal hemoglobin was. They don't know what their hemoglobin is. Doctors just don't really communicate with adult doctors don't communicate with their patients the way a pediatrician would. Because the pediatrician is trying to reassure the parent and tell them, we're really teaching the parent, not the patient. Our patient is too young to know that. And this is just something to remind me about pain. But I tell patients, you know, between the beginning of pain and the end of pain, it could be a week. So once their child had pain, the worst part would be from day 3 to the end when it went away. But we try to teach them that this is not, you know, it's not pain for a day or an hour. It's a lot of pain for a long time. And we had pain plans for children. So the pain plan was good for the parents. So they would get a feeling about, they would have like a diary, and they could bring this pain plan, which was signed by me, to the emergency room and say, hey, this is what Dr. Keith thinks my kid should get for pain, and how often you should be evaluating him and all that kind of stuff. So they actually had pain plans, and adults should have a pain plan. People do, kids are cute, so everybody loves kids, but adults, they need to have a pain plan. They go to the emergency room and they've been there like this is the third time in 3 months or 2 months. Immediately people think, oh, this person's not having pain. They're just here to get the Dilaudid. And then the patient says, hey, I take 3 milligrams of Dilaudid every 2 hours for 3 doses and I'm better. And the doctors think, oh, bullshit. This person wants the Dilaudid. But if you have a pain plan, then you have a signed plan. You hand it to the doctor and say, this is what my doctor recommends for me when I'm having a pain episode. And here's his phone number if you don't think it's true. And then you can once you have an advocate who's a doctor and the person knows you've got a doctor, then the whole interaction changes, because they don't want to deal with another doctor who knows more about sickle cell than they do. So that's really important. It's really important. And remember to, anyway, that's sort of my spiel on pain. And we did a lot of screening for sickle cell. We monitored their CBC. We actually did vision and hearing. Retinopathy is really common in sickle cell disease, especially SC. About 20% of kids with SC have damage to their eyes, and you can pick it up when they're as young as 10 because they can cooperate a little bit. And we'd send them to the ophthalmologist. They'd look in their eye and they could tell whether or not the person had retinopathy, and it's treatable. If you don't do anything, it leads to blindness. So I had a patient who was incarcerated with SC, and when he got discharged and came to see me, he was blind. He was not totally blind, but he was functionally blind. And they didn't do anything. He never got any treatment. So it's really serious. Retinopathy needs to be identified and treated. We did the transcranial Doppler till kids were 16. We did MRIs. We sent people to the dentist. We did pulmonary function, and then we reviewed to make sure that if someone wasn't on hydroxyurea, maybe they would benefit from it. We did that. This is I've talked about hydroxyurea, but basically this was my criteria. The one thing that I really learned when I was taking care of kids with sickle cell was a lot of them were missing school due to pain or other sickle cell problems. And once they started hydroxyurea, they just kept going to school, and they had no more absences. There is stuff that you need to do if someone's on hydroxyurea. So you need to have an experienced physician to take care of you if you're on hydroxyurea. I'm not trying to go through this pretty fast because I want to get to transition, but basically at school age, we stopped seeing kids with this S beta plus thal as often, but for other kids, we just kept seeing the same. A lot of people stopped penicillin at 5 years. I actually didn't. I talked to the parents about it, and most of them opted to keep kids on penicillin. Most of the patients that I saw die from infection were around somewhere between 9 and 10 or 8 to 10. They were older and they weren't taking penicillin. I don't think I had any children die from infection who were actually taking penicillin. And then we continued the immunizations. The 504 plan is something that children need. It's in order that they get hydration all the time at school, especially during physical education. They need to have bathroom privileges. They can leave the class to go to the bathroom. People with sickle cell can't concentrate urine, so they go to the bathroom more than other people, especially if they're keeping hydrated. Academic support is needed. I'd actually ask the parents to bring me in any evaluations or grades, and we'd go over them. And then we would ask for IEPs or individual plans if they were warranted. And then if kids were really having trouble, we would get neuropsychological testing. It wasn't always easy, but we would do our best. And then we talked about behavior, socialization, self-image. Kids with sickle cell disease, they sometimes have scleral icterus or yellow eyes. The white part of their eyes turn yellow. They're smaller. They miss a lot of school. So it's really hard for them to go to school. And we had a handbook for teachers, and we started talking about medications at school. Should you have ibuprofen? Most schools wouldn't let you have something like Tylenol with codeine or anything else, and no opioids at school, but you could have ibuprofen. And then who to contact and who I was. And this
Dr.
is
Keith, real quick, just to interrupt you, going back very quickly to the hydroxyurea, with I had a question from Nadina. With all the new therapies that are coming out, do you still recommend using hydroxyurea even with everything else that's coming out?
Yeah, for sure, because the studies were done, and some studies, 60% of the people who were on the study were also on hydroxyurea. So you don't really know for sure whether hydroxyurea had an effect on the study because so many people were on it. And there's never been a study of, say, Oxbryta and hydroxyurea head to head. So, and the way they work is
so
completely,
it is tested and proven.
Yeah, even for
tested and proven.
Even for adults. I have doctors who I'm still in contact with, and they really are advocating hydroxyurea versus one of these new drugs. I think they're good, but there are some issues with some of them. You know, crizolizumab is probably, I think that's going to turn out to be a good drug. The problem is you have to go in for an IV infusion to get it. But, you know, it's not that big a deal, especially if it makes your life better. But that's sort of my take on that.
Gotcha. And then have you?
And then
ahead,
some
Pat.
of the patients complain a lot about pain with some of the drugs, and that has not been the case with hydroxyurea.
No.
We've known that hydroxyurea started very, very early on when we started newborn screening, and we've been able to increase the life expectancies of people with sickle cell disease by volumes just by using hydroxyurea. And those medicines can be coupled with the new medicines. Hydroxyurea can still be used even if you're using new medicines.
Gotcha. And that was actually the follow-up question that was asked. Have you noticed any synergies between the drugs and hydroxyurea, or any severe interactions, or maybe even like super positive reactions or interactions between the two?
I have a patient who I still know who was on hydroxyurea and Oxbryta, and she quit the Oxbryta because it increased pain. Actually, it increases your hemoglobin, but it doesn't replace your hemoglobin. It just increases your sickle hemoglobin, right? So she stopped taking that and stayed on the hydroxyurea. That's the only one that I know. But you know, when you release a drug to the general population, then you start finding out all these kind of unusual reactions that you didn't see in the study. And, you know, it could be you weren't looking for them either. So that's why you didn't see them. So
Or it could be the patients didn't report them because they felt like nobody else was reporting it.
Yeah. So this is more screening. We tested for pulmonary hypertension.
I want to say something. A lot of the trials and a lot of the new therapies that are coming out are really tested on men and not necessarily females. Do you have anything to add to that or substantiate why that is what it is? Because even with COVID, I mean, I'm sure that they have tested all of these drugs and all these vaccines. However, they're not necessarily testing them on females and the like is all I'm going to say. So any comments on that?
I don't really remember seeing, I don't know how many women were in the studies compared to men, but women tend to have more pain because menses is associated with pain. So they shouldn't be excluded for a lot of reasons. Part of it is all the studies if you have to take a pregnancy test. So nobody, which is going to change in the future, but nobody wants to give medication that's not approved or the safety is really unknown to someone who's pregnant. So that eliminates, not a lot, but it may discourage some women from participating because they figure, oh, wow, if I get pregnant, I'm gonna have to drop out of the study. Or I won't know I'm pregnant, unlike some of the laws in this country where they think you should know day one. I may not know I'm pregnant for like 2 months, and I've been taking this drug for that long a time, and I don't want to take the risk, so that could be the reason, but I don't know what the mix of male, female was in all the different studies. So by age 12, we start to begin transition, and that's an important milestone for kids with sickle cell disease. We did pulmonary function, treatment with bronchodilators. There's no evidence that it changes the course of pulmonary disease and sickle cell disease, but people with sickle cell disease have a lot more pulmonary problems. And eventually, asthma is a vaso or bronchoconstriction, which you can open up with these bronchodilators and steroid inhalers, decrease inflammation. But the progression of disease into adulthood goes from bronchoconstriction or asthma to restrictive lung disease, where it's not the air passages, it's the lungs themselves are being damaged by the sickle cell, and you have restrictive lung disease, which is progressive through adulthood. And it's not been shown that bronchodilators or other drugs affect that. Risk factors for acute chest syndrome is acute chest syndrome before 4 years, asthma and allergies. Asthma and allergies were big risk factors for severe lung disease. And of course, probably the more acute chest syndrome episodes you have, the worse your outcome is going to be pulmonary wise. And this just talks.
Sorry to interrupt you. We had one other question in terms of follow-up. Since you mentioned pregnancy, have you seen any adverse reactions to hydroxyurea during pregnancy?
Most women or young girls that I took care of, and some women, if they were thinking about having a child, they would stop the drug. However, there have been a handful, or maybe more now, because it's maybe more common, of women who were taking hydroxyurea during the first trimester of their pregnancy, or maybe longer, and there was no problems with children's. Hydroxyurea in super high doses, like 5 times, 10 times higher than what you'd give for therapy, is a teratogen. So in rabbits, when they gave a lot of hydroxyurea to rabbits, there were birth defects. And nobody knows what the threshold is for humans. But at the doses that are given, I've never read about any kind of birth defect or anything. What?
So Dr. Keith, have they done any follow-up studies on any of those babies to really document that? Because I've never heard that they've done any studies to either prove or disprove that hydroxyurea is a problem during pregnancy.
So there's what are called anecdotal studies where somebody will report, oh, my patient was on hydroxyurea till the second trimester or after the first trimester, and the baby was fine. I think if there was a teratogenic effect to somebody who had ever been taking hydroxyurea, that would be reportable. I mean, somebody would report that in a medical journal, and I still subscribe and read about sickle cell all the time, and I've never seen anybody report problems with pregnancy and hydroxyurea, although the recommendation is that you stop, men and women. The other thing since we're talking about hydroxyurea, the other thing with men is hydroxyurea does decrease your sperm count. Hydroxyurea works on rapidly dividing cells. So your sperm are rapidly dividing cells. It doesn't make you sterile, it just decreases your sperm count. Some people say it doesn't decrease it enough that you would be infertile, so it couldn't be like used as a birth control or something. And then once you stop the hydroxyurea, it goes right back up. And they've actually looked at children since nowadays, this is after I left medicine, nowadays, they have studies on children, males, who took hydroxyurea, say really early before the age of a year, and what is their sperm count when they're teenagers? And that's not affected at all if they stop the hydroxyurea during the time you take. So if you and your partner wanted to have a baby, then you would probably want to stop hydroxyurea because you thought it was a teratogen, and also your sperm count would go up. So that's the story on reproduction and hydroxyurea. So those are the things that we would talk about with young kids. We'd do teaching for all this kind of thing. Teaching is a big deal. We really started talking about priapism with males because most men don't want to tell you they have priapism. So you had to make it a conversation that was easy to have. And by talking about it a lot, that made it easier for the people, the children, to talk about. Early adolescence, we start really getting into transition. By 18, we wanted patients to request their own prescription. We wanted to making their own appointments. We made sure that the parent, the caregiver, understood that the patient has privacy, that we would start seeing the patients without the parent when the kids were probably 15, 16 or before. Some parents were really objected to that, especially parents of young ladies. And then we would just make sure all their immunizations were up to date, check bone density, do this, make sure these things were all normal. I was really paranoid about things falling through the cracks and kids having a problem that I never screened for. So that was part of my personal problem with that. We'd teach kids, make sure they knew how to make appointments, review inheritance, really important. I was really surprised at how little children knew about sickle cell disease when they became adolescents. Here they are, they're coming to see me a lot. And we talk about all the complications, and some of them they've been in the hospital for pain, acute chest, other problems, and you had to reteach them about sickle cell disease. So the teaching goes on for life, I guess.
Keith, let me just say this. One of our attendees said, I have restrictive lung disease.
Yes.
Several years ago, and I was having repeated pneumonia infections. So my doctor has me on a daily low dosage of penicillin, and she hasn't had pneumonia since.
That if that person was having bacterial pneumonia, penicillin, I'm not sure. I mean, it doesn't cure pneumonia, but it gives you time to go into the hospital if you get pneumonia. I don't know, I'm not aware that giving low doses of penicillin would have anything to do with restrictive lung disease or pneumonia, but obviously for this person, it could. It may be somewhat anti-inflammatory, I don't know, especially if you have, kind of low-grade infections. The issue with giving penicillin at low doses, and this was really an issue for children, was that it creates a situation where you're selecting out for penicillin-resistant bacteria, but that's another issue for another time. So adolescents, we wanted them to do all these things, make appointments, request refills, become a good historian, be able to tell a doctor in an emergency room what had happened to you and something about your sickle cell disease. And now we started, in middle adolescence, we started having the social worker actually meet with the patient to make sure that they knew about sickle cell disease. And she was the gatekeeper for people being transitioned. We didn't transition people until the social worker said, yes, this person can be transitioned. It wasn't up to me. You know, it was a joint decision, but it wasn't my decision. It was, I relied on her to tell me that this person was okay to transition. And we continued the comprehensive clinics for all these different diseases and problems.
I don't think I know that many.
And then we made sure that the patients understood all this stuff. Puberty, menarche is delayed in sickle cell disease about 2.5 years, so their periods came late. It's weight associated. The thinner you are, the lower your hemoglobin, the more this is going to drag out. Resting metabolic rate is increased in SS, so weight and height are associated with the degree of anemia, and that would depend on how you entered puberty. If you were really anemic and small, not all the time, but sometimes that would make it a little bit longer. There's very little information on delayed puberty in males, but I definitely had males who were late adolescents. Even the latest one was like in their 20s before they went through puberty. And then we talked to the women. Women have more pain episodes because during the menses, they have increased inflammation and other changes, and that increases pain. We would send the girls to our adolescent clinic and they would see GYN. We recommended progesterone-only contraception because it decreases pain events. It can decrease bone density. You need estrogen to make bones, so you have to really keep an eye on the bone density if you're on a progesterone-only contraceptive. Then we started talking, when kids got to be 17, 18, we started talking about career. Are you going to college? What are you going to do for work? How is it that you manage pain at home? How do you know when you have to come to the ED? This was part of their pain plan, but we wanted to make sure they knew, don't stay at home. What was a pain episode versus what was like impending acute chest syndrome or some other serious complication. And then we continued checking their knowledge, and then we talked about risk behavior for kids with sickle cell disease as well. So this is the really important part, is the transition to adult care. Frequently, there are when patients left my practice, well, we had an adult internist who took care of adults, but other places don't. So there are very few adult providers. There's an increase in emergency room after transition, increased complications, and increased morbidity or problems, and increased mortality or death. And I'm going to show you that in a minute. So this is a complicated graph, and this gray line right here is somewhere between 16 and 2021. So this would be the time of transition. This is when the patient or the individual leaves the pediatric practice and goes out on their own. In some cases, this was due to insurance. Insurance would not pay for a 21-year-old or even an 18-year-old to go see a pediatrician. So they had to leave the practice. CCS, Medicare, they do not cover individuals after the age of 21 to 25, somewhere in there. They do not cover pediatric hospitals to take care of those patients. So the hospital doesn't want 25-year-olds in their pediatric practice, because if they come into the hospital, they don't get paid. In any event, you can see transfusion really starts to go down. And that's because adult doctors would stop transfusions on people who are on transfusions for stroke risk, making them more at risk for stroke. There was really not too much change in hydroxyurea, but eventually it started to sort of end up going down over time. This is all complicated.
So Keith, to that statement that adult doctors stop doing transfusions. I think we have to say to people that because they are often transitioning to physicians who don't know sickle cell disease and who don't understand the significance of transfusion therapy for people with sickle cell disease, they may oftentimes stop doing transfusion therapy because they don't really understand it. And sometimes patients are at a lack for being able to explain exactly why it's important for them to remain on that transfusion therapy. So I think that what I would say to people living with sickle cell disease as they come to an age where it becomes necessary for them to transition from pediatric care, for them to make that decision prior to their providers making the decision that they're going to transition, so that they can make a concerted effort to have a transition that moves smoothly and that is a planned transition, and that they are the one orchestrating that. Because I think it's so very important for people to understand that you have to control your destiny in life. And the destiny of people with sickle cell disease is to get the best possible care, and in a society that oftentimes does not value folks with sickle cell disease, feels like they're going to die by a certain age because of lack of information, and is ill prepared to provide them the things they need. And so what I would say to you guys, as you begin to think about transition, transition needs to begin very early, where you start interviewing docs and finding out who can best align with what your needs are as a person living with sickle cell disease, and to refuse to settle for less.
Right, right. So, the thing is, people were started on transfusions during the STOP study. That's off the radar for adult doctors. They don't know about the STOP study, stroke risk, all that kind of stuff. And they don't want to deal with transfusions, because that means they have to monitor the transfusions. They have to know how much blood you're getting. They have to order the blood, which is not easy for sickle cell, because there's increased antibodies to blood in people with sickle cell, and they have to get special blood. And then they have to monitor iron chelation and iron and all that. So for them, it's simple just to say, hey, I'm not going to do this. But transfusions in the STOP study and later showed that these people were having less sickle cell problems. So a lot of the people who transitioned to adult care with Dr. Hager at Children's, they stayed on transfusions. They didn't want to have the life they had before transfusions. And they were willing, especially if they were on exchange where they didn't get iron overloaded, but they were willing to take the medicine usually in order to stay on transfusions. So you can see that all these are all complications, go up, 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 up. And they start dramatically, because look at this. This is like a 16-year-old, and all of a sudden when they're 4 years later, they have almost twice as many problems as they had when they left pediatric practice. So this is definitely a huge issue for people who have sickle cell disease, and it's documented over and over and over. This is from an old study, but nothing has really changed. So like Pat was saying, it has to be prepared, and you have to find a doctor. We actually, if Dr. Hager hadn't been there, we wouldn't have had anybody really. There were very few adult doctors who took people. And if you had private insurance, sometimes your private insurance would pay for you to see a hematologist for whatever reason. And this is the pain goes up dramatically. The thing here now is, on top of all this, is that 98% of children survive to be adults. So this affects every single person with sickle cell disease. So all children are going to survive to this point right here. You could almost say that. And then all of a sudden, the floor drops out and they have a lot of problems. And so this shows you mortality. This is death. This isn't being sick. This is being dead, right? So you can see that over here, there's the different years, and it goes from the older, where young kids were not surviving to when hydroxyurea became available right in here, the red line. So that went down, way down during the 90s because of transfusion for stroke risk, and kind of more or less stayed right there. And then all of a sudden, things get a little dicey when you're 15 to 19. But look at this. You go from 19 to 25, and you double the death rate among people with sickle cell disease. You go for another 10 years or so, and it just gets worse. This should not happen. Why isn't it just slowly going up like it would go in the general population? They're not dying over here, they're dying over here. And that is just not okay. It's something that why people advocate for adults and children with sickle cell, because they realize this is what's going to happen. And you can actually see it in this California. This was done in 2016. So here you've got 10 to 20, say, and there's more and more people, but what happened here? What happened between, oops, let me go back. What happened between here and here? What happened to all these people in 10 years? They died. Look at that. Those are the males and these are the females. Why are there so few less between 20 to 29, 30 to 39? That shouldn't happen. And it's still happening right now today. So that's a big issue.
So Keith, I think it's really, really important to discuss primary care, because most adults, most people with sickle cell disease who leave the pediatric setting and go to the adult setting are encouraged to have a primary care doctor. And that primary care doctor is actually the doctor that orchestrates your care. And I think people need to understand the importance of picking a good primary care doctor whose value of you aligns with your value of you, so that that person will do everything they can to ensure that anything that arises or rears its ugly head will be taken care of, because they will then refer you to those specialists that you absolutely need to see. So I know it's mandatory to see a hematologist at least every so often, determined by what your primary care doctor feels. But it also is important to see eye doctors. It's also important to see pulmonologists if you have a pulmonary problem, cardiologists if you have a cardiology problem. And all of those things are orchestrated by your primary care doctor. So the true test of what level of care you get really rests in the hands of you and your primary care doctor. And so how you choose that primary care doctor really has to be a purposeful choice, where you know that that person, you can communicate with them and that they are willing to listen to what you have to say and to come to your aid when you need assistance in managing your sickle cell disease. And so I just want you to understand how significant primary care doctors are. And they're not always just a doctor. They may be an internist, they may be a pulmonologist, because sometimes they'll have specialty areas, but we call them primary care doctors because that's the doctor that you are most closely aligned with and who you report all of your concerns to. And that really is a very different look from being in pediatrics, where you only see hematologists until they refer you elsewhere. Hematologists are specialists who specialize in blood disorders, but you will, as you get older, see primary care doctors who specialize in seeing all kinds of things. But when there's a need for more participation in your care in that particular field, they'll be referring you to a specialty doctor.
Right. And the other thing
that's really important to know.
And the other thing is, if you want to participate in studies, you have to, your primary care doctor is a gateway to care. If you want to see a pulmonologist, you have to have a referral. If you want to see the cardiologist, all those people, you need to have a referral, including research. So if you want, say you wanted to participate in a gene study that you heard about at Children's or something, But if you didn't have a primary care physician, you can't be in a study because you have to be referred to the study center. You can't walk into Children's Hospital and go to see Mark Walters and say, hey, I want a gene therapy. I want to be in your study. That would be really unusual because you need to be referred, I think this patient, it would be a good patient for your study. They have whatever. And that's how you get into studies. It's so critical to have a primary care physician. It just can't be understated. And they're hard to find. It's hard to find walking into a new situation, and sometimes doctors are busy and they seem like they're cutting you off, even though they may not be a terrible doctor. But after a few visits, you have to realize does this person have my best interest at heart? Does he want me to be healthy? And if you can't convince yourself after a few months or whatever that that's the case, then you have to figure out how to get a doctor. And
so that's what, Keith, why it's so important to have an elevator speech. You go in there and you have to sell the doctor. You have to help them to understand who you are, what your needs are, and how they can best serve your needs, and whether they are willing to serve your needs. And once you make your elevator pitch, then you evaluate those responses from that doctor, and you decide whether that's a doctor that you feel is qualified or are worthy of taking care of you. I think we have to help people to understand their value, and your value is whatever you decide your value is. And so finding the right doctor really has to do with how you feel about yourself and how you promote yourself in a way that person understands how important you are to become part of their practice as well, and can show you the compassion and the care. And I always tell patients, build your doctor. They don't have to know everything about sickle cell disease. You can teach them about sickle cell disease. You can have other people teach them about sickle cell disease, but they have to have your best interest at heart. And so it's so very important to choose a primary care doctor who addresses you and who respects you in that regard.
And I think the point there from Pat is you have to convince the doctor, you have to show the doctor that you have worth and you're worth taking care of, and that you are not just another, patient. Because in reality, people with sickle cell disease are not easy to take care of. Most people, don't have medical problems until they're in their 70s or something like that. So it's like federally funded healthcare centers. They are, if there's one near you, that's something to investigate. They have several doctors. You can pick one out. They have, in order to get federal funding, they have to have a social worker. They have to have some kind of clinical psychologist or a psychological social worker. They have to have nurse practitioners and nurses. So those could possibly be a gateway into good medical care. I have Kaiser, so I know that I get, if I have a question, I get whoever happens to be answering. But I think it's really hard, and don't give up. You are worth the time to take whatever it takes to find a good doctor. And you can go to the Sickle Cell Disease Association of America. They might have a list. You can go to other resources to try to find somebody who's your friends even. If you know other people in the community around where you live, though they know what's going on with adult doctors. And if you have, and as a 20 plus year old, you need to just, before you transition or whatever, if you still have contact with your pediatrician, really get them to get you somebody who's who's good. It's not easy, but it's worth it because this is your life. And your life could really be impacted by having not such a great doctor, or maybe he's a great doctor, he just doesn't really have your best interest at heart.
And even asking your previous doctor to speak with that doctor because you have some concerns about whether that doctor actually is going to meet your needs or not. To get their opinion about what they think about the doctor may be helpful, or an advocate or someone else who you think might be better positioned to interview that person and share to see if they have the same concerns for you and your care related to your hooking up with this particular doctor. I think sometimes we have to when you have sickle cell disease, or you have some medical condition that not everybody really understands, it's not an easy condition to work with. We sometimes have to employ other folks to help us to make good decisions about who is going to care for us and what is acceptable and what's not acceptable. And as Dr. Keith says, sometimes people with sickle cell disease, all the years I've worked with them, sometimes they're not really easy to work with, but the possibilities are enormous, and sometimes we have to convince people with sickle cell disease that though we're not communicating in the same way, that we see your work, we see your value. And you have to convince them also that you see the value of them taking care of you, because you are a person who deserves the very best like anybody else does. So again, build your doctor, build your health care, ensure that you get all of the things that you think are necessary for you to get good health care. Make sure that your doctor speaks to you in a way that you guys have a line of communication. If the person is disrespectful, maybe that's not the person for you. If they're a person who doesn't understand what you're trying to communicate with them, maybe they're not the person for you. And so it is an ongoing process. Sometimes you'll meet a doctor who you think might work and later find out they don't work for you. But you have to feel free to really interview and explore your options in terms of selecting a doctor, or deciding that is not the doctor for you.
And I just want to chime in here at Sickle Cell Anemia Awareness that we are practicing our 90-second elevator pitch, because we recognize that, people's time is limited and there's a lot going on in the world. But we are here and we are practicing to be better advocates for clients and be able to support legislation and understand how it all works. So just know that that's definitely in the forefront of sickle cell anemia awareness. And we recognize that there's a great need. And I just want to thank Dr. Keith and Ms. Corley for all of their input and information, because it is very valuable. And all of the conversations that we have had in exchange today is going to be viable for us in the coming months, because we have to step up, and all of the clients and their supporters, advocates, and caregivers, we need all of those people to support what we're trying to accomplish and get things changed for the sickle cell community. Thank you all so much. And that's all.
Yes, thank you, Dr. Carollo and Ms. Corley, for your information. It was kind of hard to hear Ms. Corley every now and again through the background. We know you're in Tennessee, so hopefully you're still enjoying your trip, but thank you for that information. If anybody had any questions on any of the things that they mentioned, we could go ahead and take these next 5 minutes, 10 minutes to do a little Q&A. Anybody wanted to ask some follow-up questions or had some concerns or comments that they wanted to make for Dr. Q and Nurse Corley, go ahead and make those at this point in juncture. I'll give you guys about 5 minutes. Go for it. Julie, did you have something you wanted to voice?
Oh, yes, I really enjoyed and appreciate the presentations. And my questions were answered. but I would like to see something more comprehensive on adults, because that the presentation, as far as I could see, it 90% of it might have been for adolescent, and I know Dr. Carollo, that's his specialty, but that's my position where I am right now. I've done the pediatric part of it, so now I need to know more. Got lots and lots of concerns right now.
Gotcha. No, and that makes sense. And I think Dr. Carollo pointed out that fact is sadly, that's kind of a reflection of the sickle cell community at current. Like they get all the information, everything that they need pediatric. And as soon as they get to that 18 point, it's all of a sudden no man's land. You know, you have to fight for your own. And there's not really a lot of help out there. And that's kind of what we're trying to change, which is why we bring this program to light, just to show, you know, kind of the steps of the process. I think Dr. Carollo or Nurse Corley could maybe add a little bit more information as to the adolescent side of it, to the adult side of it.
Yeah, so I totally agree with that. Yeah, I mean, I know a lot about pediatrics and some of it flows over into adults, but adults tend to have different problems and usually more problems. You know, and the other thing is, as a pediatrician, I took care of kids from when they were 2 months old. You think about that. I took care of kids through their entire lives. And the type of caring and understanding that I had for them, you can't really, it's difficult to recapitulate that in an adult doctor, because all of a sudden you appear in their office and you're 25 or something. So they don't know anything about you. And they don't have you have to it's like you're being reborn, sort of. You have to reestablish that. That's really difficult to do. But I agree that, you know, knowing more about it depends on where you are, but knowing more about what's available, how do you go about finding a doctor? I mean, I had a hard time finding doctors for my patients outside of Dr. Hager. If they lived in Stockton or Fresno or someplace, and people came from that for Sacramento, it was hard to find a primary care doctor for everybody. It was really difficult. So I think that's a big issue to look at. And I think you have somebody who's looking into that, right? Who's you have somebody sending out a survey to doctors in California, which won't happen immediately, but at some point that would be an interesting survey to present.
Yes, we are conducting some surveys through the CDC, trying to gather information on particulars for medical care providers in terms of their knowledge on SC, and then what services they do or don't provide if they are available for SC treatment.
Right, that's going to be a very important. If that can come to fruition, that's really important, because it will shine a light on at least what's going on in California. And I think the CDC, there's 5 states, I can't remember which ones they are, North Carolina, and some others, but there are 5 states together who work with the CDC and with California, Susan Policonis. And so if this is successful, it could be branched out to the whole country.
Definitely. Michelle, you had a question?
I was just going to say thank you. It's been a long time coming, but I just want to say, well, I am an adult patient, and I did live in California before for some years, and I think I may have seen you before, but this is back in 96 to 90. I think I moved back to Colorado in 2004, and there's not a lot of information out there for the patients or the parents. And I work with the Colorado Board of Sickle Cell, and they call and they ask questions, or they're wanting to know things, and we just don't have the support, even with like some of the doctors, you know. And it's really hard the parents, and they're not being told about the resources, told about things in the community, or ways that like the support group that we're with too. We have an adult support group, and they're not being told about these things. So the people go to the hospital, they leave, and we can't get no information from them because of HIPAA. The doctors, they don't want to tell us anything, which by God's grace, the Ms. Donna Dixon, that's over the sickle cell board, she knows everyone, but it's like those new people that slip through the crack. I would like to know some more stuff about the adult side, but we have been putting things into place like that, as far as like pain management and telling them. And like you said, they do the same thing. They don't want to hear what we have to say. They don't want us to tell them that, okay, I can't take that, or I need this much of this, or, and it's like, you try to do all the right things, and it's just still, it's not enough. But I just thank you for this empowerment. I mean, it is empowerment. I'm believing God that more things will come out, that we'll be able to help others, help more people, and get the word out that we really need their support, So thank you to everyone that's on here. Pat.
So I actually work for a couple of community-based organizations, and one of them is called Sickle Cell 101. You probably never heard. Yeah, so I'm available. If you have a parent who's really looking for information, they can contact me through Sickle Cell 101. Okay. If you go to their Facebook page, it'll say Ask an Expert. Now it used to say Ask Dr. Q. But if you click on that, you can send me an email, or twice a month I'm online on Facebook and Instagram, and people ask questions online for me.
Wow, okay. I just direct them to Donna if I don't know it, because right. She's like the expert for us, and I know she's like wore out, but we really need more. I mean, they didn't even have the school thing when I was growing up. They didn't have the school thing of information for the patients and stuff, and I actually went a step further and did the 504 plan for my children, because they had the trait, but some of them were having some issues. And so I was like, oh, I seen that what you put up about being in school, and knowing, letting the teachers and stuff know, and they're being knowledgeable of what's going on with that child and how to adhere to that child and help them. But for me, I mean, I'm so happy to see that they're having that right now, because they didn't have that for me. They didn't have that when I was in school. I mean, I didn't learn a lot of things until after I got out of school. I didn't even know that I wasn't supposed to be swimming. I wasn't supposed to be overexerting myself, like running and being in weightlifting and stuff. I would go home every day because I would be hurting and spitting and coughing and stuff after running the field. And I never knew none of that stuff. And part of it, I know, is because my father kept it from me, but he didn't want me to know all of the things that was going on with me or what could happen, because how fear can set in. And so I was been walking by faith for many years. So God is so good. But yeah, thank you.
The thing about my impression of parents is that everybody who goes to a doctor is sort of a selective listener. They kind of hear what they want to hear. So I don't know your dad, of course, but it could be that he just didn't acknowledge what he knew. And so he just didn't. We're very complicated. We may know things, and we just our biases and our thinking processes don't always help us out. And I can imagine if my kid had sickle cell disease, there are parents who just keep things from their kids. They don't want to tell them because it's too painful. Because to tell you that you had sickle cell and all this stuff going on with you, it's painful for the parent. They have to admit, they have to come to grips with the fact, well, you know, this child is in the world because I have trait. But most people, your parents had no idea they had trait. There was no testing. So they just, you know, even a guy named Koff, you probably don't know who he is, but he was a pediatrician from Ghana, came to this country. He ran a sickle cell program. He's like the epitome of the sickle cell doctor. He went back to Ghana because that's where he was from. He had sickle cell trait and he didn't know it. His wife had sickle cell trait, she didn't know it. And they had a kid with sickle cell disease.
Mhm.
And it was, even though he was noted, everybody in the world knew who he was. He had trouble finding care for his kid in Pennsylvania, in Philadelphia. He couldn't find care. And he, you know, once his kid was in his 20s and 30s, you know, your kids, they're on your own, sort of, you know. But
Yeah.
it was amazing. At one ASH meeting in front of thousands of people, this is so sad. He and his wife got up to tell the audience how awful it was to have a kid with sickle cell and how hard it was for him to get care, even though he was like the most well-known pediatrician for sickle cell disease in the country. And he couldn't find the information he needed for his kid. I mean, it's a huge problem. If he couldn't do it, then how could you do it, or any other just normal person? And I think that goes across the board, but it just underlines the fact that this is such a huge problem that needs to be resolved. And unfortunately, you know, this is my, you know, bias, I guess, or whatever, because I'm white, I don't know, and I don't have sickle cell, what do I know, you know? But it seems like the things that happen for Black people in this country were done by Black people. White people don't always step up to the plate when they should. So I think it's really important to have community-based organizations, to be organized, to be vocal. You know, like Pat was saying, you matter, you count, you're a person. You deserve the best medical care. You deserve to have a full life and not have the kind of some of the issues that people with sickle cell disease have. And that's your right. And you just, unfortunately, in this country, you just have to fight for that tooth and nail. No one's going to give you anything here. It's just not going to happen.
No, unfortunately, the American dream is very individualistic. It's not about us as a country. It's about what you can do for yourself. So until those mindsets start changing, and you know, the dream is more about making this country as a whole, including everyone in it, great, we're always going to come to this impasse and have to struggle just to kind of have our own voices heard, which is kind of sad. Not kind of, is actually very sad. So, you know, those are the realities. Those are the things that our organization, other organizations, nonprofits are trying to fight, and hopefully come up with a better future for us as a nation in terms of being able to not just fight for our own causes, but fight for everybody's cause and kind of just be unified in a direction. You know, it might not be the best direction or the right direction, but as long as we're all on the same page, I feel like, but we're not. Everybody's on their own page, and that's the biggest issue I see.
But
Any other comments, questions?
You have to realize, unless everybody gets health care, everybody gets equality, then nobody has it. It's
Exactly.
not, if people with sickle cell disease aren't getting good health care, then that means nobody's getting good health care. So, okay.
Any other questions, comments? Thank you for that, Michelle. That was a great little expose. Ali, now that you're on, you can actually speak about the survey you sent to doctors. Dr. Carollo mentioned it earlier. Have you gotten any information that's new and relevant towards maybe possibly providing more information for adults that are transitioning out of the pediatric care?
It would be good to have somebody. I think I can ask some people. I only know the people at Children's. I know a few people at UC Davis, but Maybe Pat knows people in Southern California who would be able to do this. Adult care is really important, and I just don't know, like pregnancy, I don't know anything. I had very few kids who
Right.
were pregnant. So
So
those
I
things
have
are really important.
Yeah, so I have spent the last year tapping some of the doctors that we trained at USC who are now out in the community who are willing, actually, if you can sell them on sickle cell to take care of people with sickle cell disease. I think we just really are going to have to really work harder at trying to get these people to come on board and take care of people with sickle cell disease. Part of it is helping them to understand the value of doing it and how rewarding it actually is. So that is my goal. I am working hard toward developing a database of adult practitioners who are not necessarily hematologists, but who are people who are willing to take care of people with sickle cell.
Right. That's probably what we need. That's what is that we need to get together. All right. It is 1:30. I don't want to keep anybody else past what they're past the 1:30 mark, because I know we're having a long day already and we want to enjoy our weekend, but this was all great information. Again, stay tuned for the last and next episode, which will be next month, the second Saturday of next month. I don't have my calendar on me right now. Hold on, let me just pull it up real quick. It'll be August 13th. And the last and next AEP session will be August 13th. Same time, same bat channel. Make sure that you log in. One little quick update that I want everybody to be aware of is for our organization, we started a new channel called the Excel channel. And actually, our first series is for local resources in California that sickle cell patients, advocates, and caregivers can go to and figure out everything that is available to you. As we mentioned, one of the biggest problems is that not everybody knows what's out there. Not everybody knows what's available to you. So we actually had a community healthcare worker, Alon Hunt, actually go through the steps of not only filling one application out for one resource, but also all the resources that are available here in California and a couple that she knows nationwide as well. So tune in for that. It'll be on our YouTube channel. So you can just go to our website at www.scaasf.org to find our YouTube channel. And on the YouTube channel, you'll see our new feature, the Excel channel. We have a feature on the backpack there, and we also have our first episode up. So feel free to go ahead and gather as much information on that as you can. It's super informative. It's great. And we'll put out another flyer for that, advertising that channel as well. That's all from me. Hopefully you guys all have... What's up?
Nadina, can you stay on for a second, Nadina, if you can hear me, and Kimball too, maybe?
Yeah.
I just have some updates about the survey that we created that I just wanted to share.
Okay, sounds good. Yeah, we'll stay on, Ali. Don't worry. Everybody else, have a beautiful, wonderful day. Keep smiling, work hard, and remember, you can be the change that you want to be. Bye.
Hey guys, how are you?
Michelle.
How are y'all doing?
We're doing well. Hold on a second. What'd you say, Dr. Keith?
Yeah, Dr. Keith is on too.
Yeah, Dr.
So I just wanted to say I've been talking with Susan since she's helping us distribute the surveys. And what we've decided, what she's done is she's basically sending out the emails to the hematologist individually instead of sending a blast email, just so to get better response rates. And we kind of agreed on that. And I think she said that in a couple, so every week she's been sending out a couple hundred. And she said that she should finish within a couple weeks. And the last time I talked to her was 2 weeks ago. And at this point, she had been done probably about a little bit more halfway from sending her first emails out to the providers. And she said that the response rate was about 20. We had 20 responses. And she was telling me, like, so far, we've sent out like 400 or 500. We've only gotten 20 responses. Do you have any ideas to like, what are your ideas to do this, since we're getting a low response right now? And what I told her was that she should send out the rest. And she had an idea of sending personal emails to some of the physicians she actually knows. And I was telling her that, sometimes when, you're sending out the first email, it often gets lost, or, they're going to say that they're going to respond in their head, and sometimes they forget, like, it happens. So we were basically saying that we should send another round of emails after the first one, like as a reminder. And then she was going to send out her personal emails to some of the physicians in California. And the last resort kind of plan was, after we send out the second emails, if we still get a low response rate, was to send out like a postcard. So far, that's the idea. And she says, the postcard requires funding that she could get, but it'll take a little bit longer time. So, I mean, that's where we're at so far. And I was wondering if you guys have, any ideas, thoughts, suggestions.
So I have a suggestion.
Yes.
And my suggestion is that you recruit the patient population to get doctors to fill out those forms, and that you give the patient population Starbucks.
Can you speak up,
card or
Pat?
something.
Pat, can you speak up?
Can you guys hear me now?
Yeah, just speak
Yes.
up.
Okay. So if you recruit the patient population to recruit the doctors that they come in contact with, and then you give the patients a gift card to Starbucks or something for doing that recruitment.
That's a good idea. The thing is, so how would we find the patient population? I guess I know we have some the people living with sickle cell disease here, and maybe get the word spread out. But how are we going to be?
Can you do that on Facebook and some of the other arenas?
We could maybe through. I feel like we need maybe we could do it through SCAA. I feel like an organization would help.
Well, we could put it on the Instagram. We could put it on our Facebook page. We could put it on the Instagram. We could put it on Twitter and just send out a blast saying, if you want to get a $25 gift card, see if you can get your doctor to fill out this survey or something like that.
Right, but then the issue is, where's that funding going to come from? And we have to, right, like, so
it's coming from us, Ali. It's coming from us through the CDC.
Okay.
Yeah, you don't worry about that, buddy. We'll take care of that, and just whatever needs to be done, we'll get it done to get that information that we need, because it's vital that we get that information.
So Ali, I have two things I could do. Shannon Kelly works at UCSF and in Oakland and over in the city, and she's done a lot of these types of surveys, and I'll ask her how she was able. Nobody ever gets more than 40 to 60%. That's the tops. That's just not. I'll ask her how she went about to contact doctors, and then I'll talk to Cassandra Trimnell, who does Sickle Cell 101, and she has thousands of followers. They're not all in California, but she has a lot. And I'll ask her if she would be willing to support your and sickle cell anemia awareness, if she would support this on her website. So she has, she's at she's on every imaginable social media. So those are the two things I can do for you.
That would be awesome. Thank you, Dr. Carollo. Yeah, I think it's a very important survey, and I believe she said that there was about 1,000 hematology providers that she has on the list. And I mean, honestly, we just want like 10%, you know, even a 10% response rate, I think I think it's feasible. Like it's something
15.
that
I want
goal.
15.
15.
I
Yeah,
want
the more the
20.
better.
I want 20.
Okay, yeah, right. But I'm not going to be crazy. If I can get 15, I'm good. It's like today we had 33 registrations and we only had 18 participants.
Mhm.
So, yeah, I'm doing my numbers here, and I'll take 15.
But yeah.
I'm
That's
sorry.
54% though.
Yeah, yeah,
That's 54%. That's pretty good.
yeah,
Yeah.
yeah. That's what I'm saying. So
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 I think 20% is feasible if we do it right.
I think sending out postcards, if you have the money to do that,
Mhm.
you know, a pre-printed postcard with the information, you know, you've got to hit people in every direction. And I think, you know, there's also like a email fatigue. If you could say, we'll stop sending you emails if you'll just fill out this form.
right. Yeah,
And just keep hitting them. It doesn't
Yeah.
cost any money
Yeah.
to send emails. Just say, you know, we'd really like your response. We'd like to stop sending this email. Please answer this. Because the survey is so simple. It's not like it, and you might say, I don't know what you
absolutely.
send. I don't know what you send people, but you could say, this survey will take 5 minutes.
Right.
Please.
That's
do
yep.
it."
That's what we said. And I think what they did is, since it was going through the CDC or tracking California, they had to edit some of the things, but I made sure that that blurb was on there. And one thing I'm kind of worrying about is, do you think that there's maybe some sort of bias within the providers, you know, when maybe they're looking at the survey and they're like, well, you know, like it's not a fault of their own that, you know, they have cruddy care for sickle cell disease, right? Like it's more of an institutional problem, and maybe they have like some sort of bias that, you know, we're like, oh, we're not that bad. I'm just not going to fill out the survey. You know, something like that. I'm worried that, I don't know if that's a factor, but
I think
I'm
that
just kind of thinking about that.
you know, the reason that we have Susan Poliakonis support is so that we can use that weight. And she stated that in earlier conversations that, you know, people respond better to this, that, or the other. And we knew that we were going to have some difficulties in that area, which gave us the opportunity and the avenue to partner and do this in conjunction, because they recognize the value of the information as well. And so,
Right.
You know, I don't know, you know, what are the forces in the universe that need to be involved to make this, you know, like, oh my goodness. But I feel like the California Department of Public Health, when they step in and they're using their letterhead and when they're using their support and backup and support, we just have to, we got to go with that. And, you know, it's like Fauci, you know what I'm saying? So that's all I got to say. You know, I'm experiencing difficulties because you all know I got COVID. So, but I wanted to get that point over in that, you know, the information that we are requiring or that we are asking for is not off the charts, and it should be, you know, some sort of mandate. See, and I had this conversation when I was talking about my 90-second elevator pitch. You know, it's just like there needs to be some mandates here to make people do this, or else, you know, it's always going to be that uphill thing. So, okay.
Could it be considered a CE, a continuing education thing? Could we possibly package it in that respect? Because everybody has to do that, right? Dr. Carollo?
Yeah, they do. And I just wonder if you know, they have, they do those webinars, like I think it's I don't know how many times a year, but a lot of people watch those. And at the beginning, they usually have some kind of a intro where they say, we're doing this, we're doing that. I think you could get Susan to help with that, but to have this be on there like every time they give a seminar, maybe. But I think you're right, Ollie. There is a bias. Doctors don't like to admit that they're not doing something that somebody thinks they should do. And they may look at this survey as, intimidating, actually, that they don't take care of people with sickle cell, and they don't know anything about it, and they just don't want to deal with it, kind of thing. But I'll talk to people and see if there's a way, to get by that. And, it's anonymous. So, I think really focus on that. We're just trying to collect information. You're not going to be identified in any way, although everybody's afraid with the way social media is that somehow somebody's going to get into your data and find out all this information about them. Although if you can assure people that's not going to happen, that might be helpful.
Well, could we parlay it with a non-disclosure form or something, or paragraph or something that way they know that all information won't, like personal information won't be disclosed. So I know, Nadina, you shake your head, but I kind of see the correlation in terms of the bias that they're talking about, because again, nobody likes to admit that they don't know something, especially doctors. And, through all the education that they go through, their humility level is very, very low. They're not used to, you don't find doctors like Dr. Carollo, even some nurses. That's what's wrong with our healthcare system. Like, people just aren't willing to be honest about things, I think you're muted, Nadine. I can't hear you.
She's muted.
Nadine, I think you're muted. We can't hear you right now at all.
I'm sorry. I don't have all the right words. I don't know all the right processes in this, but there's just been way too much conversation that we have had. And it continues to go on. We are having it right now. And I listened to you today, Keith, talking about the Panthers, and, I am just so through with all the conversation that I want to be one of them. How long are we going to talk about this before we try to fix it? Let's just think about ways to fix it, but nobody's thinking about that. It's just, it is what it is, and that's what it's been. I guess, and I'm just so done with it. I don't know what to do about it. And I'm fighting all the time mentally how to fix it, because it's not that difficult. This is not freaking rocket science. Shit. So, I thought I was through at the meeting, but I came back in and heard the rest of the conversation, and here I am right now. And I know Pat knows, because Pat and I have had several conversations about what we need to do. Dr. Raleigh, I'm just so ready to protest. I'm just so ready to carry signs. I'm just so ready to I just don't want to hear it anymore. Let's just talk about the resolutions, people. Come on.
So Nadina,
yes,
I need to talk to you, because we're working on this.
Yeah. Okay.
We are planning protests.
Please help me. I'm ready to. Please, I'm just so there. I listened to Dr. Keith today with the history of the Panthers, and all the struggles that we have dealt with, and we're still back at square one. I don't know what it's going to take, but as long as I'm on the planet, that's why I'm here. So I need to get active. We need to be active. And we've got to get some change in all of this process with people dealing with sickle cell. That's the bottom line. That's all we've asked for. That's all they wanted. I mean, I watched my son suffer. I know he died. And we had other warriors die in May because of the negligence in the system. So just help me, educate me, please.
I hear you, Nadina. I hear you, and it must be really frustrating. I know it's very frustrating. The system is just it's terrible.
Broken.
It's corrupt.
It's broken. It's
It
broken.
really is.
Yeah, and that's what we need to fight. You know, it's not. Sadly, it's not just us; it's everybody. Everybody's effed up in this system. We just need a whole rehaul. Like if we're gonna protest and make our voices heard, we need everybody on board because the whole thing needs to be redone. Everything needs to be redone. Everything needs to be redone. It's such a horrible system.
My apologies. I let my emotions get the best of me, and
It's
but
okay.
We're human.
This is
We're
a safe
human.
place, Nadina. This is the place to
Yep.
do it.
yeah,
We love you.
thank you.
We do love you. Always. Well, okay. I wanted to say that I think it would be a good idea when we're done sending out this first letter, the first round of emails, which will finish, I think, in a couple of weeks. We should all gather together, and I will create a meeting with Susan. We'll get availabilities, and we can meet all together to come up with resolutions on how we can do this. It should not take this long. I agree. Like it's just people don't care. Some people like don't understand what the idea behind it is. And it's frustrating. But I'm trying to really like work on getting this finished because I mean, eventually to create change, right? What's important is these research, like the research being done and making it known to the public that this is a really really bad thing, and this is what the survey targets, right? It was made and tailored by people living with sickle cell disease to and addressing what's lacking for them, right? And this, like, hopefully if we when we do publish this and when we get more information and we see the data, and when people actually read stuff like these are the stuff that's going to push for change, at least one of the things.
Absolutely.
And that's the goal. That is the goal. That's why I want to do this as soon as possible.
Okay, let me just say this. My nephew just graduated in Sacramento with his doctorate in education. And I want to put him in touch because he wants to do a paper. I have a paper published on the whole sickle cell environment, the community, and the rest of that. So I'm going to connect him. It was a wonderful thing. It was just an amazing situation. But yes, he has a doctorate in education. And so I'm going to put him in touch with you and Dr. Keith and Pat and all of us. We're going to be in the same email so that we can talk about how to develop this and what it all entails, and just everybody get that synergy going.
Yeah, I think Adina, your frustration is shared by all of us, and I see us working with groups who I'm not quite sure what their investment in making sure that people with sickle cell disease get everything they need is. And I think we need to sit down and talk about, we're doing research, helping people research stuff, but we aren't really doing anything to change the level and the commitment to making sure that people with sickle cell disease get good care and are respected and regarded in the way that they should be respected and regarded. So I understand all of the emphasis on all these different organizations that come into our community who collect data and information. But what is happening with really taking that and changing what happens in sickle cell disease? Because we've known for a very long time what people with sickle cell disease need. And now we're redefining it again. You know, it just gets to a point where it gets ridiculous.
Well, and I agree with you 100%, Pat. I think to go off Nadina's point, Dr. Carrillo's point, and even Ollie's point, like there's, you know, you just said it correctly. There's no investment really. They don't really, at this point, it's not like what do they have to lose? And I think for me personally, and I'm just throwing this out there, and I don't mean any disrespect to any professional in the medical field at all, or those that are studying for it. But I think if you're not going to answer any surveys, if we don't get that 20% we're looking for, we just need to put everybody on blast and be like, look, we're trying to get information from these people, and all these people have not answered. And then that'll affect their bottom line. Patients are not going to find them being publicized on Instagram, Twitter, Facebook as doctors that don't collaborate with surveys, that don't collaborate with research opportunities, that don't, and now they're losing patients. And then that'll get them, that's the investment. Because now if you don't have patients to treat, you're not really a doctor. And at that point, where's your career going? You know, and I hate to kind of go through that avenue and go through those
They don't
means, but
care about treating people with sickle cell disease.
we need to put that out there. We need to put those doctors out on blast.
Right. And you're right, Torres, because San Francisco General, you know, they're trying to really beef up their program over there, because I've been trying to put them on blast at every opportunity that I can get. Now they got a program director of the sickle cell clinic. They have a social worker that's there part-time, mind you, but they still have not extended the hours of the actual clinic to a half a day, 1 day a week. So now, come on. I get that. That's great, but come on.
But that's more than what they have down here in Southern California. They opened a new clinic that's funded, and that clinic sees patients for only a limited number of hours once a month.
Once a month.
So how are you providing any service that is beneficial?
My God, you just,
but
you're trying to kill me today, right? You're trying to kill me. You're trying to kill me right now. You know, I've been weeping. I got COVID. You're trying to kill me, right? You're trying to kill me, girlfriend. What?
But you're funded by the state of California to do that, because they gave monies to groups who are funded to ensure that we get sickle cell centers of excellence.
Yes, yes. Kiss my behind with that shit. I'm sorry.
They're crap. And there's no movement for accountability to these folks who have all this money and are going back over and over to the state to get more money.
And that's what we need. That's what we need. We need to blast these people. Like we need to put that. I didn't even know that. Like we need to go to news outlets. We need to go to Twitter. We need all this information to be out there. And that's what's gonna, if we want to start, you know, protesting, whatever we want to do, this is the way to do it. Like we're in the modern age now where we can actually go onto all these social media outlets and put these people on blast, whether or not they're our friends or not at this point. Like we just got to put everybody on blast.
In the past, there were advisory committees that housed people who cared about sickle cell disease. What we need is a committee that goes out there and says, look, we are watching you guys. We know what you're doing. You're getting money. We want to know how you're spending the money.
Right.
You cannot keep our money from the state on top of something that's already there and say you created new things.
Right.
You know,
right.
So there's just a time, you know, they say there's a time to reap and there's a time to sow. It's time for us to sow.
That's right. And I want to know what is required to be on that committee to watch these people.
You just said we have to start it, Nadina. Let's just start it ourselves.
We got to organize a committee. So I
okay.
Along with Cayenne and you guys and some of the other organizations, we were talking about a collaborative. We need to be a collaborative that puts that together and ensures that people with sickle cell disease get what they deserve. Good, equitable, you know, evidence-based care where people respect and regard them as valuable.
Yep.
Well, you know, the thing is too, Mary Brown asked for $30 million this year.
What?
twice what she got last time.
What?
And
And didn't use the money last year.
I think what you need to do is do it, Pat. You have to be a collaborative. You have to have a voice. And I think what Ollie's doing is so simple. You need to go to the legislative Black Caucus. They're the people that put the bill through. They're the reason that Mary Brown got $15 million and Carolyn Raleigh's getting zero. So I think you need to go to the root of the matter. These people are politicians. We pay their salary. They need to know that Mary Brown's group is doing nothing, that the money that they gave her, and they're giving her another 5 million to this time, is just not doing anything. And they need to know that. They need to know about Ollie's study, that he sent out all this information to people and send them the questionnaire. Say, what is going on? How can we reach the people? Because they are part of the government. That's their responsibility to take care of their constituents who are Black people. They need to
know that we as citizens of California will no longer sit by and watch them spend our money in a way that's reckless and does not benefit the population who they're supposed to be spending that money on.
Exactly.
Right. No, and the fact that there's apathy within them, this survey, there have been negative articles written. Carolyn Hoppy wrote one where you present this to some internal medicine journal and say, this is what we tried to do. This is why we tried to do it. We couldn't because none of your members would answer the friggin' questions that are innocuous. That's the only way you can put it out there that your organization does not care about sickle cell disease, and this proves it.
Yes.
So there's your response, Dina. There's your action. I agree with Corley. I agree with everybody. What we're saying, that's what we got to do now. We got to form that collaborative, and we got to light people up. I mean, I'm with you, and right now I'm fired up. I'm ready to light people up.
And we need to survey the population to find out: are you any better than you were before they gave that $5 million to the group they gave?
Oh, that's a great one. No, Pat, I can actually do that right now.
No.
You know what? I'm gonna write that survey right now.
Do you know of new services? Do you know that there are supposedly this many new clinics available?
Yeah. Oh my God.
We have the opportunity to make a change, and we need to insist that those people be accountable to us as people who are in the community, ensuring that the patients get what they need.
The other thing, though, is, you can't complain to them because they don't give a shit. They got the money. So I think you need to let the Black Caucus know, because they should be the people who care.
Yes.
I'm not talking to Mary Brown.
All this money.
I'm talking
higher ups. I'm talking to the doctors
and the legislators.
And the legislators. Yep.
Yeah. Okay, I have to go, but keep in touch.
Okay, me too, because
I'm all behind this.
What kind of meeting? Everybody's asking me, what kind of meeting is this that you're on vacation and you're on it? Nadina, I must love you to be on this meeting.
Yes, I know you do, Pat, and I feel it all the time. Your presence is effervescent in my life. So yes, we will chat. Everybody have a great rest of your day, and thank you so much. And we'll be talking.